As Dr. Pratik has already said, I am speaking on ovulation induction in non-ART cycles. By now, you all very well know the major causes of subfertility in couples, and when it comes to anovulation, it accounts for 21% of these subfertility cases. So what should be your clinical approach to ovulation induction? It requires first about the understanding of the causes of anovulation, and their four most common ovulatory disorders include polycystic ovarian syndrome, hypogonadotropic hypogonadism, primary ovarian insufficiency, and hyperprolactinemia. So we all know that ovulation induction is the method for treating anovulatory infertility. WHO categorizes ovulation disorders into three groups, and patients who are eligible for ovulation induction, they belong either to WHO group 1 or WHO group 2. WHO group 1 is hypogonadotropic hypogonadal anovulation. WHO class 2 is normogonadotropic normoestrogenic anovulation. Almost all women in this category, they are PCOS when we are using the Rotterdam criteria for the diagnosis, and this is the most common cause of anovulation. WHO class 3 is hypergonadotropic hypoestrogenic anovulation, that is primary ovarian insufficiency or premature ovarian failure. Hyperprolactinemia does not have a separate WHO category. When it comes to PCOS, the 2018 guidelines clearly tells us that lifestyle modification is the first approach towards managing anovulation in cases of PCOS. What about POI? It accounts for 5 to 10% of the cases of anovulation, and the effective option is IVF with donor oocytes. But don't forget that these women are at higher risk for osteoporosis and cardiovascular diseases later in their life. For hyperprolactinemic anovulation, which accounts for 5 to 10% of the women, they are anovulatory because hyperprolactinemia inhibits gonadotropic secretions, presumably by inhibiting GnRH. Most of these women, they will have oligomenorrhea or amenorrhea, and their serum gonadotropic concentrations are usually normal or decreased. So once you treat hyperprolactinemia, they start ovulating. So what should be your goals for ovulation induction? The goals are inducing monofollicular development rather than multifollicular. Subsequent, we want mono-ovulation, ultimately a single pregnancy, and of course a birth of a healthy newborn. I know this is a very, very idealistic goal as far as ovulation induction is concerned, but we do have many challenges when we start walking towards that goal. So what should be your general principles for ovulation induction? Remember, whatever method you are choosing for ovulation induction, it should be based on the underlying cause for an ovulation, the efficacy of that protocol, the cost, the risk incurred, patient burden, and of course, the potential complications associated with each method as they apply to that individual woman. Do we have ideal ovulation induction drug? Though we all would like to have a drug which is oral, which requires minimal monitoring of that cycle, which does not have any hostile effect on endometrium and cervical mucus, should have better ovulatory and pregnancy risk, and should have very less risk of OHSS and multiple pregnancy. There are various stimulation protocols starting from age-old clomiphene, letrozole, clomiphene plus gonadotrophins, letrozole plus gonadotrophins, gonadotrophins alone, and gonadotrophins and antagonist. Whatever is your ovulation induction protocol, you should remember when to start your stimulation. Remember, it has to be in the early follicular phase, because the recruitment of the follicle takes place in the early follicular phase. In the late follicular phase, your recruited follicle, they only grow in size. So first, coming to the clomiphene, it was the first drug of choice. We all know this drug since last 55 years. Simple to use, cost effective, has fewer complications. It has two isomers, that is zooclomiphene and N-clomiphene. N-clomiphene is the more potent isomer with greater anti-estrogenic activity, and this is one which is primarily responsible for inducing follicular development. This is the mechanism of action of the clomiphene citrate. How you should select your patient if you want to use clomiphene citrate. Remember, for using clomiphene citrate, some amount of endogenous estrogen is necessary for a response to clomiphene. Women with PCOS, they do produce estrogen. You can use this clomiphene, but now our PCOS guidelines are telling us that letrozole is the drug of choice as far as ovulation induction in PCOS is concerned. Do you have to confirm the ovulatory disorder before you start ovulation induction? So how you will go about it? What should be your pre-treatment evaluation? Remember, before initiating therapy, the presence of ovulatory dysfunction must be established. And for this, if you take a careful menstrual history, this alone may suffice, because if she is having a regular cycle, it means that she is ovulating. But if you are uncertain as far as ovulation aspect is concerned, you can take help of some non-invasive tests such as basal body temperature, urinary LH monitoring, although the luteal phase serum progesterone is more confirmatory. Basal body temperature we don't use routinely, but you should know that absence of a 0.5 degree Fahrenheit rise on measurement of basal body temperature. If you are measuring mid-luteal serum progesterone, then it has to be less than 2. Lack of an LS surge on your urinary LH monitoring. Out of phase time endometrial biopsy, which we are never doing in our OPD practice. And lack of a periovulatory follicle on serial transvaginal sonography. So you can take help of these non-invasive tests to find out whether your patient is ovulating or not. Before starting ovulation induction, you should rule out the disorders of pituitary, adrenal, and thyroid origin, because if you correct these disorders, these patients, they will start ovulating without help of your ovulation induction protocols. So before starting therapy, complete history, physical examination is must. Semen analysis is must, because nowadays 30 to 40% of patients, they are having male factor. Of course, pelvic examination, don't forget to do per speculum, PV examination, and then do transvaginal sonography. Is tubal patency mandatory before you go ahead for ovulation induction in IUI cycles? Not necessary if she is a low risk for tubal pathology, but if she is a high risk for tubal factor, you have to go ahead and assess her tubal factor. What about ovarian reserve test? It has to be individualized. It can be dependent on the age of the woman. Of course, antral follicular count should be done on day 2 scan by yourself. AMH, I leave it to you all whether to do it or not, because it has to be an individual consideration. Whether it is CC or letrozole, it has to be started on day 2 or day 3 of the cycle. What dose? The literature says you should start with the 50 milligram and then go on in an increment of 50 milligram. Never exceed a dose of 150 milligram, because it is not recommended, and the ASRM suggests that doses more than 100 milligram add very little to your clinical pregnancy rate. Once ovulation is achieved, the same dose should be continued for 4 to 6 cycles. Failure of ovulation is clomiphene resistance. This is for about 20 to 25% of unovulatory women are CC resistant. Whereas failure of pregnancy despite ovulation is clomiphene failure. When you should stop clomiphene citrate? Of course, if you are not getting response within first 3 to 4 cycles, either you have to change the therapy or you should go on to other modalities of treatment. If your patient is on oral ovulagens and you are planning timed intercourse, not IUI, then ultrasound monitoring is not mandatory. You can monitor this cycle by LH urinary kit. And remember, when you are monitoring by this method, the LH surge typically occurs 5 to 12 days after clomiphene administration is completed. So ovulation generally occurs 14 to 26 hours after the detection of the urinary LH surge and almost always within 48 hours. So therefore, the interval of highest fertility is the day of the LH surge and following 2 days. Basal body temperature, as I said, we are not doing in our practice. If you want to do serum progesterone, a mid-luteal, that is 1 week after ovulation or 1 week before the expected menses, serum progesterone concentration greater than 3, ideally greater than 10 nanogram per ml, provides reliable evidence that ovulation has occurred. What is the outcome as far as clomiphene citrate is concerned? You can see that it has an ovulatory rate of 80% and a cumulative pregnancy rate of 30 to 40%. Of those who ovulate, approximately 50% they do so at a dose of 50 milligram, another 20 to 25% at 100 milligram, and 10% at 150 milligram. There is no benefit to increase the clomiphene dose in subsequent cycles once ovulation has occurred. Why this pregnancy rate is so low as compared to the ovulation rate? You all know that it has an anti-estrogenic effect which contributes to the reduced pregnancy rates. So do we have any strategies to counteract this anti-estrogenic effect? You can try giving half dose of clomiphene, that is 25 milligram per day. You can start from day 1 or you can add exogenous estrogens. The ovulatory rate, remember, is lower if the maternal age is higher, if her BMI is more, if there is insulin resistance and there is a higher free androgen index. After 6 months of treatment, the pregnancy rate per cycle falls substantially despite regular ovulation. The incidence of miscarriage and congenital anomalies, they appear to be similar to that in spontaneous pregnancies, and the rate of ectopic pregnancy is probably not increased. The risk of OHSS with clomiphene is less than 1%. Risk of multiple gestation is very, very less, but be careful, it is not nil or zero. What about the perinatal outcome? The various studies suggest that the frequencies of congenital malformations and spontaneous abortions are not increased in pregnancies after clomiphene therapy. Can you have more success rate if you are using higher dose of clomiphene, like to the tune of 200 to 250? It is not advisable and it is not approved by US FDA. Always remember the adverse side effects. I know we all use left and right clomiphene, but it does have certain side effects in the form of hot flushes in 10 to 20% of women, and there might be additional problems like abdominal distension, nausea, vomiting, and breast discomfort. These side effects are not dose related as they can occur even at 50 milligram of dose. Serious side effects are in the form of visual disturbances. There are no adverse effects as far as or increased cancer risk as far as clomiphene is concerned. The next drug is letrozole, which is now the drug of choice, which is the first drug as far as ovulation induction agent is concerned. It is the third generation aromatase inhibitor, and this is the mechanism of action. The standard dose regime is 2.5 to 7.5 milligram daily, and it can be adjusted in 2.5 milligram increments. It has to be started on day 2 and day 3, or day 2 or day 3. The advantages of letrozole over clomiphene citrate are many. The first and foremost is that it does not have any anti-estrogenic effect. The blood flow of the uterus is increased, the OHSS risk is low, multiple pregnancy risk is also low. So definitely there are various studies which have shown that letrozole is superior to clomiphene citrate as far as your live birth rates are concerned. For women who are having BMI more than 30, again, letrozole is preferred over clomiphene as an ovulation induction agent. Miscarriage rates are similar whether you are using clomiphene or letrozole. This is a rare case which I definitely would like to share with you all students, because you should not relax if you are using letrozole. This is very much there in the literature. This woman was taking letrozole. She was 32 years old and she was not having any response with 2.5 or 5 milligram, but she developed 5 follicles on 7.5 milligram. She was advised to abstain from intercourse, which she did not. And at 7 weeks, she was noted to have a sextuplete pregnancy. Of course, it was reduced to twins. But this case highlights that even if you are using clomiphene or letrozole, always be aware about the risk of multiple pregnancy. It also has certain side effects in the form of hot flushes, fatigue, and dizziness. It is very safe as far as fetal safety is concerned. Can you use insulin sensitizers all alone as an ovulation induction agent? No, but yes, if you like, you can combine it with clomiphene citrate, but there are various studies which has shown that this does not appear to improve the live birth rates when you are giving metformin alone or in combination with clomiphene citrate. So CC could be combined with metformin rather than persisting with CC alone in those women who are having PCOS, who are CC resistant with anovulatory infertility and no other infertility factors to improve ovulation and pregnancy rates. So this was all about oral ovulagens. Now coming to the gonadotropins for your IUI stimulation. So there are various indications for using gonadotropins for IUI stimulation. The question comes which gonadotropins you should use, whether it should be HMG, highly purified HMG, urinary FSH, highly purified FSH, and recombinant FSH. There are various studies which are showing that no gonadotropin is superior to another when it comes to your ovulation induction protocols for non-IVF cycles are concerned. I have quoted only one study. They found that there were no differences in clinical pregnancy or live birth rates whether you have used recombinant FSH or urinary gonadotropins. When you are using gonadotropins, you have to remember certain practical points. First and foremost is the cost of the intervention, the expertise required for your gonadotropin stimulation, the intensive monitoring which is required, implications for potential multiple pregnancy, the risk of OHSS, and remember, most cost-effective gonadotropin should be used because these are the two major problems, so you should be very well aware of it. Of course, with gonadotropins also, our aim of stimulation is the same, that is monofollicular development. So what should be your starting dose? It depends on age of the woman, your antral follicular count, and what is the AMH. And as Dr. Pratik Tambe was teaching you all, if this woman has already undergone ovulation induction in her previous cycles, So what was the response? What was the drug used? What dose was used? How she was monitored? And what was the response to that previous cycle? That all previous history will help you in deciding the dose of ovulation induction agent in this cycle. There are various gonadotrophin protocol. In the conventional gonadotrophin protocol, the starting dose is 150 international units per day. However, this regimen is associated with a multiple pregnancy rate of up to 36% and OHSS risk is up to 14%. So just to make your life easy, you can use, if she's less than 35 years, non-PCO, you can start with 150, but if she's PCO, start with 75. If she's more than 35, so whether she's PCO or non-PCO, you can start with 150. Once you have started, remember it has to be started on day 2. Give it for day 2, 3, 4, 5, 6. On day 7, call her for transvaginal sonography and you have to focus on those follicles which are more than 10 millimeter in size. So if there are 2 to 3 follicle, continue with the same dose. 4 to 6, you have to continue with same or you can taper. But if there are more than 6 follicles, you have to taper the dose and look for OHSS. If the follicle size is less than 10 millimeter, you have to increase the dose. When you should give trigger, if it is a gonadotrophin cycle, when the lead follicle size is 18 millimeter, the trigger should be given. This is low dose step up protocol. It is designed to allow the FSH threshold to be reached gradually, minimizing excessive stimulation and therefore the risk of development of multiple follicles. So this is the step up protocol, that is you start with either 37.5 or 75 and then you gradually increase the dose of your gonadotrophins. Low dose step down protocol is there, but I am just telling you to complete the talk and all the gonadotrophin induction protocols. This is not preferred in clinical practice because you are starting with higher dose and then gradually you are decreasing the dose. The robustness of the step down regimen in everyday practice remains to be evaluated and hence the low dose step up protocol is considered as the first choice of treatment. Now, what is the advantage if you want to combine the oral ovulagens along with gonadotrophins? Yes, there are higher pregnancy rate than with CC alone, more cost effective, but you are only saving the cost of only 2 or 3 injections, less multiple pregnancy rates, lower incidence of OHSS. If you are combining it with CC, anti-estrogenic effect will be there. The regimen is same whether you are combining it with letrozole or with gonadotrophins. So if you are using both, then on day 2, 3, 4, you are giving oral ovulagens. 5, 6, you are starting your gonadotrophins along with oral ovulagens. Day 7, 8, you are giving gonadotrophins alone. And day 9 onwards, you are monitoring this cycle by transvaginal ultrasound as I have already told you. GnRH antagonist for IUI cycles is not routinely done. It is used only if you are converting your IUI cycles to IVF cycles, or if you want to avoid your weekends IUI, you add antagonist for 1 or 2 days. Gonadotrophin cycle ultrasound monitoring is mandatory for number and size of follicles and the pattern and thickness of the follicle. What are the criteria for follicle maturity? That a follicle diameter is of 18 millimeter or a serum estradiol concentration is 200 picogram per ml per dominant follicle. When you should give trigger, if it is a CC plus gonadotrophin cycle, 18 to 20 millimeter. If it is only oral ovulagens, at 20 to 22 millimeter. What should be the dose? 5,000 to 10,000 IU. You can use urinary HCG or you can use recombinant. If you are using recombinant, remember a dose of 250 microgram of recombinant HCG appears to be equivalent to your standard dose of 5000 urinary SCG. When you are using gonadotropins, everyone should be well aware about the OHSS that can be mild, moderate, severe, and how to manage OHSS if it occurs. But you should try to avoid if there are 2 or 3 follicles of 18 millimeter size. You should write on your case paper that they should refrain from they should do abstinence, and you are not supposed to do IUI, that is cancel your cycle. Why I have added this laparoscopic ovarian diathermy in this talk? Because this is an alternative second line therapy for women with PCOS. It works, it has its own advantages if you are using it in highly selected cases, particularly in those who are having high levels of LH, who are having normal BMI, those who need laparoscopic assessment anyway for other reasons, those who cannot come to your hospital for frequent monitoring, those who cannot afford the gonadotropin injections, then yes, do think of laparoscopic ovarian diathermy. It is not outdated, but yes, it should be used judiciously and in selected patients. Luteal phase support, I know there will be a talk, separate talk, but with oral ovulagens, it is not compulsory. But when you are using gonadotropins, luteal phase support is mandatory. Now, when you should refer your patient to IVF specialist. Remember, IVF is the method of choice if duration of infertility is more than 3 years, if the woman's age is on higher side, IVF should be considered earlier. If you refer early, then there are many advantages to that particular woman, because her chances of becoming pregnant with IVF is higher, there is increase in live birth rate, and there is reduction in the recurrent pregnancy loss. So to summarize my talk, the method of ovulation induction selected by you should be based on the underlying cause of anovulation, the efficacy, cost, risk, burden of the treatment, and potential complications associated with each method as they apply to individual women. Don't generalize. Every woman is different. So it has to be an individualized approach. For oligoovulatory women with PCOS who are undergoing ovulation induction, letrozole is the first line therapy over clomiphene citrate regardless of the patient's BMI. For obese women with PCOS, lifestyle changes and weight loss is an initial strategy to restore the ovulatory cycles. If ovulation agents are unsuccessful, then gonadotropins should be considered. Strict attention to follicle number is essential to avoid multiple gestation and OHSS. To minimize the risk of multiple gestation and OHSS in PCOS, gonadotropin should be stopped if there are an excess number of follicles or there is an extremely high serum estradiol concentration. For those women who are having POI, it's entirely a different chapter where you have to refer her for IVF. For women who are having hyperprolactinomic anovulation, ovulation induction with dopamine agonist with either bromocriptine or cabergoline will help them. While there has been a concern about a possible increased risk of ovarian cancer with ovulation induction drugs, it appears that the risk may be due to the infertility itself rather than the medications used to treat that subfertility. However, because one study suggested that an increased risk of ovarian cancer after 12 cycles of clomiphene citrate, women should never receive more than 12 cycles of clomiphene citrate in her entire lifetime. And there does not appear to be an increased risk of breast cancer with ovulation induction drugs. So dear students, it is not what you give, but it is the way you give it that will give you an optimum, the pregnancy rate and the live birth rate. So thank you so much. If there are any questions, I will be pleased to answer your queries and questions.